So hi guys, welcome to the Finals Crash Course series. So today we'll be going over Haematology and Oncology. So we've got Dr. Andrew Hugh here and myself, I'm Atch, and we'll be going through some SBAs and just kind of teaching you some key bits of Haematology and Oncology that will help you with your exams. And just a quick shout out to our contributor, Dr. Anaya Scott, who also helped kind of look through the presentation and stuff. Cool. So as we go through, there's quite a lot of SBAs here, so please do put your answers in the chat and we'll give you about 20 to 30 seconds to answer the question and then we'll go through the answers. So I'm going to hand off to Andrew now.
Okay, thank you very much. And thank you to everyone joining us this evening. It's quite late, so I appreciate you coming. I'm Andrew, as previously said, and I'll be doing some of the SBAs. We've got a wide variety of topics in hematology and oncology, and hopefully we can get through these and learn something along the way. So, part one, very nice picture. So what I'll do is I'll read through the question, I'll give you guys a bit of time to answer, and then I'll explain what needs to be explained, essentially. So let's start off with question one. So I'll read it. A 3-year-old boy with known sickle cell disease attends the pediatric assessment unit. His mother describes a 5-day history of cough, coryza and fever. On examination, the patient is apathetic, pallid and looks unwell and has a noticeable erythematous rash across the cheeks. Initial bloods are notable for a hemoglobin of 62 with reticulocytes of 0.1%. The patient's father tells you he's worried as the patient's sister had recently been admitted to hospital with a similar presentation and required multiple transfusions. So what, in this case, is the most likely cause of this patient's presentation? So I'll give you guys 30 seconds or so to answer, and feel free to post anything in the chat if it's the answer or if you have any questions about this. Okay, have we not got any answers yet, or is my computer lagging, which it can be?
Can't see any answers in the chat just yet. Should we just give them about 10 more seconds, maybe?
Yeah, a bit longer, I think.
Yeah. Guys,
I promise not all of the questions are this hard.
Yeah, just have a go. It doesn't really matter what you put down.
Okay, we've got one person who said D so far. One who said B. Okay. A bit of division. Lots of D and B. Interesting, interesting. Okay, right. I'll reveal the answer then. The answer is actually, in fact, A. So I'll talk a bit about why this is. So this patient has a history of cough, coryza and fever for 5 days. And they also have this erythematous rash across the cheeks. This is a very typical history for a disease called erythema infectiosum, or fifth disease. It's associated with the slapped cheek rash. You might have heard of that. It's caused by the virus parvovirus B19. And there's an interesting relationship between someone with sickle cell disease who contracts parvovirus. So parvovirus affects cells in the bone marrow. What it does is it prevents new red blood cells from being produced in the bone marrow. So for someone with sickle cell disease who has a degree of anemia anyway, once they develop or once they contract parvovirus, they develop a profound anemia very quickly, and the bone marrow isn't able to produce any more red cells, so no reticulocytes, are produced, which are essentially immature red blood cells released by the bone marrow. So no new red cell production and a parvovirus history with known sickle cell disease, something called aplastic crisis. Now D and B, so D is sequestration crisis. That is splenic sequestration. That's often where the sickle cells block vasculature in the spleen, resulting in a very painful splenomegaly. And usually we'd have to treat that with supportive management and potentially with splenectomy. B, though, is autoimmune hemolytic anemia. So autoimmune hemolytic anemia is not usually associated with this type of finding on a single best answer question. It's usually associated with some blood tests, which we'll talk about. It's also a hemolytic anemia. So someone presumably doesn't have bone marrow failure and they'll still be able to produce red blood cells. So they'll still have a normal or high level of reticulocytes, Okay, so let's move on to the next question. So question 2 here, we've got some bloods. A 13-year-old boy attended ED with confusion, vomiting and headache following minor head injury 3 days ago. His mother recounted a history of prolonged epistaxis, ecchymoses, and a need for a transfusion once in the past. He had experienced umbilical cord bleeding after birth. On examination, right-sided hemiplegia was found and subsequent CT head revealed intracerebral bleed. Abnormality in which clotting factor is most likely to cause the patient? I'll give you guys a few seconds to answer. Okay, we've got a couple of B's so far. I'll just wait a smidge longer to see if there's any other responses. Okay, that's all right. So I'll reveal the answer. Well, we've got one E as well. Okay, I'll reveal the answer now. The answer actually is D, factor 13. So this is an SBA that's quite likely to appear. This presentation is quite typical for SBAs. So what we have is someone with a pretty strong bleeding diathesis history. They have a high propensity to bleed, but their clotting screen is pretty much okay, actually. There's not really anything abnormal there. They do, of course, have an anemia in their full blood count. So someone with a bleeding history but normal clotting screen, one of the top differentials is factor 13 deficiency. And I'll explain a bit about why that is. And it's all due to the clotting cascade. So I'm sure everyone has revised this coagulation cascade to death. And it's probably worth a whole talk in itself, to be honest. But I'll go over it very quickly, just so we're clear. So the clotting cascade, it describes the production of fibrin. And of course, secondary hemostasis is achieved by a fibrin mesh and activated platelets blocking and forming a clot, right? So fibrin is formed by thrombin, and the production of thrombin is the common pathway. And then there's two pathways which lead into the common pathway. We have the extrinsic side, which is triggered by trauma or tissue damage resulting in the release of tissue factor. And then we have the intrinsic side, which is where damaged endothelial surfaces activate clotting factors that are free in the plasma. And both of these lead to the common pathway. So I always like to think about it like the intrinsic pathway. Any derangement or deficiency in clotting factors there is going to cause a prolonged APTT on your coagulation screen. But any deficiency in clotting factors on the extrinsic side is going to cause a prolonged PT. And of course, if you have problems in the common pathway, it's going to affect your PT and your APTT. So in this case, the clotting screen was normal. And that's because the clotting screen describes the production of fibrin, but factor 13 actually acts after fibrin has been produced, helping the strands of fibrin form this cross-linked mesh. And because it occurs after the clotting cascade, it doesn't cause a derangement in your standard coagulation screen. So remember, someone with a history of tendency to bleed and normal clotting cascade, or normal clotting screen, sorry, which is essentially a normal clotting cascade, always think about factor 13. So the answers that we got, there's some B's and E. So B is factor 8. Factor 8 causes hemophilia. Now think about it, factor 8 is on the intrinsic side. What we would expect it to cause is a prolonged APTT. There's also E, von Willebrand factor, and interestingly, von Willebrand factor usually causes a prolonged APTT as well in deficiency, especially in SBAs. That's because it binds to factor 8 and prevents its degradation. Okay, so the next question. So a 37-year-old female with a known history of lupus presents with jaundice and fatigue. On examination, the patient is visibly jaundiced with a malar rash. Routine bloods reveal anemia, and further investigations are ordered as shown below. And we've got a nice variety of bloods. What is the most likely underlying cause of the patient's anemia? Now I'll give you some time to read the blood tests. Okay, we have some B's. Just a few more seconds. Okay, we have some B's, I think. So I am inclined to agree with you. So very well done, guys. These bloods, the blood tests themselves, are very suggestive of autoimmune hemolytic anemia, which is B. So I've gone through, I've put these annotations to show you that this patient most likely has a hemolytic anemia of some kind, especially with jaundice. Remember, bilirubin is the breakdown product of hemoglobin, and low haptoglobin. I like to think of haptoglobin as a sponge that mops up any free hemoglobin. So of course, hemolytic anemia resulting in the release of hemoglobin, the haptoglobin is going to mop it all up and the level that's left is going to be low. So we have hemolytic anemia. And in this patient, the reticulocytes are high, which means that the bone marrow is working as intended. There's no bone marrow failure. Probably the most important test is the direct antiglobulin test, or the Coombs test. A positive Coombs test, a direct one, means that some sort of antibody has been raised against the surface of the red cells, and that occurs in autoimmune hemolytic anemia. People with lupus do develop autoimmune hemolytic anemia, but they can develop anemias of other types too. But it's the direct antiglobulin test which shows us that it's autoimmune. Okay. Good. So the next question, question 4. A 61-year-old female presents to her GP with a 3-day history of non-productive cough and fever. She has a recent diagnosis of breast cancer, for which she has received her first cycle of chemotherapy 10 days ago. She tells you she had a fever of 38.3 degrees last night, but her temperature is currently 37.6 degrees with paracetamol. On inspection, the patient is coryzal, with auscultation revealing faint crackles at the right lung base. COVID test is negative. So what should your initial management plan consist of? Okay, some very fast answers here, all at ease. Okay, that's very good. So, of course, the answer is E. So this question, this patient has recently had chemotherapy. She's going to be at risk of neutropenia. Anyone with a fever and signs of being unwell and who's at risk of neutropenia is at risk of neutropenic sepsis. That's an emergency. And so they need to go to hospital immediately for an assessment and, in this case, some IV antibiotics. What we would do is do the sepsis 6, which I'm sure you've heard of. If they come to their GP and they're unwell, we don't even need to take any bloods. We send them to hospital immediately because they're at risk of this potential emergency. And of course, paracetamol masking the fever doesn't mean that the disease has gone away. They're still at risk. Okay, so question 5. A 25-year-old female presents to her GP after experiencing fatigue and malaise. She had recently been on ciprofloxacin to treat a UTI. The patient tells you that every time she takes antibiotics for UTI, such as ciprofloxacin or nitrofurantoin, she feels unwell. On examination, the patient was pale, with mild scleral icterus and sublingual jaundice. Bilirubin was found to be elevated and a blood film was taken. Based on the results, what further investigation would you order to confirm your top differential? Okay, we've got some C's. Just a few more seconds. Okay, very well done, guys. The answer is, of course, C, as you said. So this history is quite typical for something called G6PD deficiency. So this patient, every time she takes antibiotics or has an infection, she feels really unwell, and that's presumably because she's developed this anemia, which is making her feel unwell. The fact that she has signs of jaundice and raised bilirubin with anemia probably points to a hemolytic anemia going on. And the blood film shows Heinz bodies, bite and blister cells, and schistocytes. All of these together point towards something called G6PD deficiency. I have this slide here. So this image was very kindly provided to me, and it's a very nice summary of the different red cell findings in blood film. In this case, the patient had schistocytes, which are the fragments of red cells, and that's usually due to them being broken down in some way, so it's some kind of hemolytic anemia. There were also bite cells, blister cells, and Heinz bodies. So we need to think about what G6P deficiency is to understand why we get these types of cells, right? So G6PD is an enzyme, it's part of the pathway that mops up free radicals. So if you're deficient in that, your red cells are going to be exposed or at risk of oxidative stress and damage, especially during times of stress like infections, but it can also be a reaction to antibiotics. If you have lots of free radicals, your proteins get denatured, including hemoglobin, and that can aggregate into inclusion bodies like Heinz bodies, which is why we see them in G6PD. When these red blood cells pass through the spleen in splenic filtration, the abnormal proteins, the Heinz bodies, are removed, and that results in parts of the red cells being taken away, and that can cause the blister cell or bite cell appearance. And they're both caused by the splenic filtration in this case. And the top right picture is what a real bite cell looks like on a blood film. Okay, so the next question, question 6. A 40-year-old female clinically deteriorates after receiving induction chemotherapy for a recent diagnosis of Burkitt's lymphoma. Bloods are taken, revealing acute kidney injury, raised potassium, raised phosphate, raised LDH, and low calcium. Management of the patient's clinical syndrome may involve all of the following except, and we'll give you 30 seconds. Okay, we've got 1E, a few more seconds. Okay, I think we'll leave it there. So, okay, we've got 1A as well. So, the answer that I was looking for from this question was E, urinary alkalinization. So, the recent chemotherapy for a lymphoma and all of these deranged electrolytes and AKI point towards tumor lysis syndrome. Now, the way that we manage tumor lysis syndrome is by managing the deranged electrolytes. And of course, we can try and prevent the electrolytes from being deranged as well. For someone's raised uric acid, which is one of the problems in tumor lysis syndrome, we can use rasburicase, which is essentially recombinant urate oxidase, that can metabolize your uric acid into allantoin so it can be excreted in the kidneys. Allopurinol therapy can actually be used in tumor lysis syndrome. It's not first line anymore, rasburicase is, but it still can be used. It can also be used in prevention. So it works by blocking the formation of new uric acid. So it doesn't deal with the uric acid that's already floating around in the blood, but it does prevent the formation of new uric acid. And so it does have some role in tumor lysis syndrome, especially if someone is intolerant to resveratrol for whatever reason. Of course, giving someone fluids not containing potassium or hemofiltration to manage any acidosis are really important. Urinary alkalinization doesn't have a role in tumor lysis syndrome. It's potentially used to manage poisons and overdose, but not really in tumor lysis syndrome. Okay, so question 7. A 71-year-old male attends his GP for a routine checkup. He describes persistent lower back pain with hip pain, alongside feeling generally unwell with worsening shortness of breath and fatigue. The nurse takes his weight and notes that he has lost 9 kilograms since his last checkup, which was last year. You take a routine set of bloods, the results of which are shown. What further test would be the most useful to identify the underlying pathology? Okay, just a few more seconds. Okay, so we have some D's, that's good. So the answer is of course D, as you've suggested. Now this patient's history, they have back pain, signs of anemia, and also these potentially B symptoms like weight loss. They seem to have a slightly low white cell count as well as an anemia with an AKI and hypercalcemia. All of these things point towards a diagnosis of multiple myeloma. So multiple myeloma is a cancer of the plasma cells, the cells that produce antibodies. And I always like to remember the symptoms for multiple myeloma as CRAB, which is an acronym. C for high calcium, R for renal failure or AKI, A for anemia, and B for bone pain. So you get bone lesions like lytic lesions or compression fractures, which may warrant a skeletal survey or a CT, probably not an X-ray, like in the multiple choice. Diagnostically, we do a bone marrow biopsy, which should show lots of plasma cells, more than 10% usually, and evidence of the monoclonal protein, which is produced by these abnormal plasma cells. You can either pick up that protein in the serum with serum protein electrophoresis or in the urine protein electrophoresis. And questions may mention the Bence-Jones protein. These days, you may also see things like serum-free light chain restriction as well. Remember, if there's no organ damage or tissue damage, we don't call it multiple myeloma, but we call it MGUS or MGUS, which is a monoclonal gammopathy of undetermined significance, which is something that you might also see in your SBAs. So just be aware of that. Okay, so moving on to the next question. Question 8. An 18-year-old female presents with symptoms of tiredness and lack of energy. Her past medical history is unremarkable, apart from a history of heavy menstrual bleeding. An anemia screen is requested to investigate the cause of the patient's symptoms. Which of the following would not be expected in the patient's iron studies? Okay, just a few more seconds. All right, so we've got some E's. Actually, the answer that I have here is D, actually. So, of course, the heavy menstrual bleeding can produce iron deficiency anemia. So the reason for D is that usually we'd expect to see a high level of transferrin in someone with iron deficiency anemia. So transferrin is, of course, the iron transport protein. So if someone is deficient in iron, the body responds by trying to increase the level of iron absorption from dietary means, and so it will increase the level of transferrin to pick up this additional iron. This means that the level of transferrin is usually higher in someone with an iron deficiency anemia, although there's more sites for binding of iron, but not a lot of iron that actually binds to the sites. So the transferrin saturation is low, although the transferrin itself would be higher than normal. And of course, a low saturation of transferrin means there's a high total iron binding capacity. So there's lots of free sites that iron can bind to because there's not enough iron. Okay, so the next question. A 65-year-old female presented to ED with a 10-day history of fatigue, poor appetite, and vomiting. Notably, her past medical history included chronic lymphocytic leukemia 3 years ago, treated with chemotherapy only, for which she was in remission. On examination, there was pyrexia with left-sided abdominal tenderness and palpable splenomegaly. There was also a new painless left-sided cervical lymphadenopathy. So out of the following, what would be the most likely diagnosis? Okay, no responses yet. I'll give it a few more seconds. Okay, we have some E's and D's. Right, okay, I'll reveal the answer then. So the answer that this question was looking for was E, non-Hodgkin lymphoma. So this is a patient with a known history of CLL. However, suddenly her B symptoms are worsening. She also has this new lymphadenopathy. That potentially could be lymphoma. So someone with new lymphoma on a background of CLL, we always have to think about something called Richter's transformation or Richter's syndrome. This is where the CLL transforms into a more aggressive form of lymphoma, meaning that someone is suddenly a lot more symptomatic than they were in the past. The raised LDH could represent that, but remember, someone might have a slightly high LDH with leukemia anyway. There's of course an AKI and an anemia on the bloods as well. The aggressive form of lymphoma, of course, comes from the lymphocytes, the B cells. It could be something like a diffuse large B cell lymphoma or other types, of course, but usually it's a non-Hodgkin lymphoma, and it's something that we always need to look out for. It's quite rare in real life, the Richter's transformation, but it's definitely common in MCQs. So in this case, someone said autoimmune hemolytic anemia. Less likely in this case. I mean, the patient does have an anemia, but their bilirubin isn't raised. So I think that's the main argument against hemolytic anemia in that case. Okay, and our final question. A 5-year-old girl is brought to her GP by her parents with fever, fatigue, malaise, and nausea. Her father tells you he initially thought she had caught the flu, but her symptoms have persisted for weeks and have not been getting better. The patient has a trisomy 21 karyotype, but has otherwise no relevant past medical history. On examination, the patient is unwell in appearance. The abdomen is distended with palpable hepatosplenomegaly. Inspection of the leg shows multiple large bruises at different stages of healing. What is your top differential diagnosis? Okay, some very fast answers this time. Okay, so I'll reveal the answer. Of course, as you've all suggested, the answer is A, acute lymphoblastic leukemia, so well done. There's a few things that point towards a diagnosis of ALL. So we have these B symptoms. They're in a child. The child also has Down's syndrome. They have an anemia with low platelets, but their white blood cells are sky high and are predominantly lymphocytes. All these things give us a picture of acute lymphoblastic leukemia. Of course, ALL is the most common leukemia in children and is associated with Down syndrome as well as other genetic disorders as well, like NF1. It does result in potentially very high white blood cells or very low white blood cells. And then, of course, the low platelets gives us the multiple large bruising. Finally, I just put this slide up very quickly. It has some blood films for each of the 4 main categories of leukemia. Actually, the AML is probably a bone marrow biopsy, not a blood film, but the cells that it shows are still consistent with AML. So when we're doing SBAs, there's a few things that point towards a particular category of leukemia. As we discussed for ALL, children is one of them, Down syndrome or NF1, these kind of genetic disorders. And the blood film usually mentions blast cells, which would be lymphoblast cells. But for AML, this is a very common leukemia in the elderly, and some questions may give a past history of MDS or a myelodysplastic syndrome, because that can transform into an AML. Blood film talks about myeloblast cells and also our rods. So this blood film, right in the center,
of that blood film is one cell with an hour rod quite prominently in it. And you can actually see hour rods in some of the neighboring cells as well. It's a very thin purplish line seen within the cytoplasm of the cell. And it's a very typical finding in AML. So just quickly talking about the other types, CML, its median age of diagnosis is about 65. So it's straddling the adults, the general adult and elderly. The SBAs love talking about the Philadelphia chromosome, which might be called the translocation between chromosome 9 and 22. They may also talk about the protein it produces. It's a fusion protein called BCR-ABL. So if you see that, you're probably thinking CML. The blood film shows myeloid cell types. Now, the myeloid cells are things like your neutrophils, monocytes, granulocytes, right? As well as, your basophils and eosinophils. So we see a lot of those in the blood film. And finally, CLL. It's the most common leukemia in adults in general. It's associated with Richter's transformation to an aggressive lymphoma, which you may see in MCQs. And the blood film will show smear cells. So we can see 3 smear cells on that blood film. These white blood cells, when they have been spread out on the blood film, they have broken, causing the smeared-like appearance. Okay, and that's all from me, actually. That's all the questions I have to present. So thank you very much for listening and participating. If you do have any questions, please pop them in the chat and I'll do my best to answer them. Okay, please explain the blood results in question 9. Let's have a look. Let's quickly get back. Right, okay. So this patient is in remission for chronic lymphocytic leukemia. They have a hemoglobin of 88. The white cells are on the lower end of normal and the platelets are okay. They have an AKI and a raised LDH. So remember, LDH is a non-specific blood test result. It's associated with a variety of things. Any stress and infection and cell breakdown can cause a raised LDH. Sometimes patients with chronic lymphocytic leukemia, even though they're asymptomatic, may have a raised LDH. But when there's a new raised LDH with symptoms of lymphoma, we're thinking, oh, potentially Richter's transformation is going on. We have an AKI, potentially related to cell breakdown and products getting stuck in the kidneys. And the anemia could be related to anemia of chronic disease, but it can also be related to infiltration of the bone marrow. So if abnormal cells invade the bone marrow, they will render the bone marrow unable to produce red blood cells normally. And that can result in a slightly low level of white blood cells or platelets as well. Okay, hopefully that helps, but please let me know if you want me to clarify anything. All right, you're welcome.
All right, so I'm Ad, and I'll be doing part 2 of Haematology and Oncology. Andrew's kindly gone through quite a lot of the detail, so hopefully we can whiz through this, and quite a bit of it should be revision from what he said. So start off with the first SBA here. So we've got an 87-year-old gentleman who's admitted into hospital due to a chest infection. Past medical history includes atrial fibrillation, for which he takes Warfarin, and type 2 diabetes, for which he takes metformin. He's been in hospital for 4 days and is slowly improving, and his bloods are done before his discharge. His inflammatory markers have come down, but the INR is 6.2. Which of these is likely to be the cause of this increase in his INR? So if you guys, I'll give you about 30 seconds if you want to put your answers in the chat. Okay, can't see any answers in the chat right now. Okay, so the answer is A. So therapeutic range for warfarin is typically between 2 and 3, whereas in a healthy person we expect it to be between 0.8 and 1.2. So the rest of this here, so you got Coamox, which is something else that can cause the INR to go up, but it's typically seen if they've got a history of kidney or liver impairment. Haloperidol, having low vitamin K and metformin actually lowers the effect of warfarin, so it makes you a bit more clotty, a bit more bleedy. Slide in just to kind of highlight the drugs which can increase the effects of warfarin. So typically antibiotics do have a tendency to increase your INR when it interacts with warfarin. Amiodarone, aspirin, azathioprine, antifungals and simvastatin are all other common drugs that you'll see on, especially in Jerry's, that may interact with warfarin. And then here I've just put a couple of the common drugs which can decrease the effect of warfarin as well. So rifampicin, oral contraceptives, so we know those increase the risk of DVTs. Antithyroid drugs, phenytoin, and of course vitamin K as well. So next question. So a very quick one. Which of these tests are specific to investigating the intrinsic pathway? So I'll give you a few seconds to think and put your answers in the chat. Okay, so we've got a few A's here. So A is the correct answer. So your APTT looks at your intrinsic pathway. Your INR and your PT both look at the extrinsic pathway, and the INR also looks at the common pathway too. And your thrombin time tests for how fast the fibrinogen converts into fibrin. And then your bleeding time assesses kind of platelet function and the levels of platelets. And I'm not going to repeat this, but I've also put the clotting cascade here just for you guys to have a look for reference. So your next question. So you got a 17-year-old girl who's admitted with a bleeding abnormality. She suffers from heavy periods and has been to hospital due to prolonged epistaxis. She has blood taken, and your consultant has asked you to interpret the following panel. What's the likely diagnosis? So I'll give you a bit of time to go look through the bloods. I can't see any answers in the chat. Just give you a bit more time. Ooh, okay, so got loads of A's coming through. So the answer is A, so von Willebrand disease. So your von Willebrand factor is produced by your megakaryocytes, and it's stored within the platelets themselves. In von Willebrand disease, the blood's not clotting properly, so the bleeding time is prolonged, and that's because of the platelet dysfunction. And so in here, you'll see that the PTT your APTT are both slightly raised. Your bleeding time is significantly raised as well. And then you'll see your platelets will be much lower. And factor 9 can, well, actually, I don't know why that's highlighted actually. I think that was a bit of an error on my part. But just to highlight the key factors in each of these tests, for PTT, it's factor 7, factor 12, factor 11, factor 9, 8, 10, 5 and 2. Your APTT tests for your 7, 10, 5, 2 and 1. So those are key ones to remember, especially when you're looking at other things like liver failure, which affects your vitamin K factors. So that's your 10, 9, 7 and 2. So that can also cause these things to be raised because they get tested by each of these tests. With Hemophilia A, you'll have low factor 8, and Hemophilia B, you'd have low factor 9. Thalassemia, you'll have more of a microcytic anemia picture, and for that you'd look at the MCV and compare it with the HB. So HB is a normal range here, and the MCV is just about within the normal range too. And then on the next slide, I found this table quite useful, so I put this in there just to help you kind of compare each of the different bleeding disorders and compare it to the different tests that you can do. Okay, so next question. So you got a 42-year-old woman who comes in with excessive PR bleed. She has known ulcerative colitis. Bloods are done and her HB is 52. She's admitted into hospital and a transfusion is arranged. So observations are taken at the start and they're all within range. So her rest rate's 14, heart rate's 89, blood pressure's 122/76, SATs are 99% on room air, and her temperature is 36.5, so she's afebrile. So 3 hours after the transfusion, she becomes short of breath. Her observations are her rest rate's 25, so she's tachypneic, heart rate's 102, blood pressure is 161/99, SATs are 89% on room air, and temperature is 36.5. The patient stating she is struggling to breathe and is able to speak in full sentences. She started on furosemide. Which of the following transfusion reactions does she have? Okay, so getting quite a few B's here. The answer is B. So this patient's got transfusion-associated circulatory overload. So just to go through the other ones first. So with anaphylaxis, any sort of transfusion reaction itself, that's more likely to happen immediately. And with all of those, you'd want to stop the transfusion or slow it down. So if you've got anaphylaxis, you'd stop the reaction and it requires IM adrenaline. With D, you'd want to check the blood products and make sure it's the right blood type that's being transfused. With E, you'd want to monitor them. So in some cases, you might just slow down the transfusion itself and give them a bit of paracetamol and just keep monitoring them to see if you actually need to stop the transfusion. With C, transfusion-related acute lung injury, it usually includes a fever as well. Both B and C are delayed reactions which can occur within that 6-hour period post-transfusion. C and B both also require oxygen support at times. The main difference here is with B, you don't have a fever and it's responsive to furosemide. I should have, there we go. So there's like a little table which I found which is quite useful, which compares both of these reactions. So your Trally and your Toco, and then any other supporting data that you can use to help. So with your transfusion associated circulatory overload, you'd also look for any kind of elevated BMP to look at the size of the heart, any vascular congestion which might have predisposed them to getting this. Okay. And this is your general kind of guideline of what to do if they've got any sort of reactions, which I put in there just as a reference for your revision. So your next SVA, got a 45-year-old male who comes to the GP. He's been feeling quite low and a bit more irritable than usual recently. He also noted that he's struggling to think clearly, feels quite fatigued and had recurring headaches. Past medical history suggests he has some form of inflammatory bowel disease. You suspect anemia. Which of the following would you expect to find in the patient's blood test? Put your answers in the chat. And just give it a few more seconds. Okay, so the answer is A. So with any sort of chronic disease, you're more likely to get a more microcytic anemia picture. In some cases, you can get normocytic anemia too. But main reason for this is you end, especially with the background of IBD, you're likely to have iron deficiency anemia, which is typically a microcytic anemia. And then I put this diagram I got online, which just divides up the 3 different types of anemia. So your microcytic, your normocytic, and your macrocytic. So common microcytic anemias are your iron deficiency of any, so could be of chronic disease or just having an iron deficient diet. Your thalassemias, and you can get sideroblastic anemia, which we'll be going through in a bit. Your normocytic anemias are usually related to sort of acute scenarios, so any sort of blood loss, for example, or it'll be any sort of early stages of iron deficiency or chronic disease. Any aplastic anemias. If there's any defects to your red blood cells too, and any sort of extrinsic causes which are affecting the blood too. And your macrocytic anemia, the common ones that you want to keep in mind are your folate and your B12 deficiencies, and your liver disease and alcohol kind of link in with that. Okay. So next question. A mother brings her 8-year-old son into A&E as she is concerned that he doesn't seem himself and had been having bloody diarrhea. On blood test, you notice he is anemic, thrombocytopenic, and has an acute kidney injury. You request blood film, which shows MAR. Which bacteria is associated with this condition? So your MAHA is your microangiopathic hemolytic anemia. Got one answer so far. Okay, getting a few more coming in. Give it a couple more seconds. Okay, so the answer is C. So E. coli is your common bacteria that affects causes an infection in MAHA, and it's typically E. coli 157, which forms this sugar toxin, which causes this sort of picture of your hemolytic uremic syndrome. And so you have a triad for hemolytic uremic syndrome, which is your AKI and your thrombocytopenia, which you see here, as well as your microangiopathic hemolytic anemia that you see on the blood film. And if I go to this slide, here you can see these schistocytes, which are these crescent-shaped cells that you'll see on the blood film. And this is usually due to this kind of mechanical destruction of your red blood cells. And then these are a few others that you want to differentiate with, and these are different causes of MAHA. So your thrombotic thrombocytopenic purpura usually presents with like bruising, bleeding, any sort of neurological symptoms like headaches, for example, and it has a combination of MAHA with low platelets, and it's usually tends to be drug-induced, congenital, or due to pregnancy. The other one that you see in pregnancy is HELP syndrome, which is kind of characterized by your hemolysis, elevated liver enzymes, and your low platelets. The other one is your disseminated intravascular coagulopathy, which is linked to sepsis or malignancy, can also be seen in pregnancy or any sort of transfusion reactions. And on blood tests, you'll see this prolonged PT and APTT, as well as low platelets and a MAHA picture. But the MAHA is not specific to your disseminated intravascular coagulation when you look at the blood films. So it's just kind of linking it with the other things that go in the clinical picture. And just going back to your hemolytic uremic syndrome, it's usually occurs in children, about 90% of it, and it's usually diarrhea associated. Okay. Next SBA, so you've got a 25-year-old woman who presents with a one-day history of painful right leg, which is erythemesis and tender. She states that this is a recurring problem over the past couple years. On further questioning, she reveals her mother died of a PE. She has also been in hospital due to a PE after travelling back from Australia last year. What is the likely underlying cause? You put your answers in the chat. I'll give it a few more seconds. Okay, so I think people put down C. The answer is actually E. So factor V Leiden is the most common cause of inherited thrombophilia. So the picture here, it's a recurring problem that she's had over the past couple of years, and the sort of family history of someone passing away from a PE, so having a hypercoagulable state, and that she's also had a PE kind of points towards a cause for inherited thrombophilia. SLE can cause a hypercoagulable state when they have this kind of antiphospholipid syndrome picture. The other symptoms that she has, she doesn't really have any other symptoms which point towards malignancy, which rules that one out. And if she did have liver failure, it's more likely to cause her to bleed more than make her form clots. And factor II deficiency, it wouldn't cause clotting. So I took this image off from osmosis, which I thought was quite good, and it kind of put everything together to help you guys with your revision. It just links in your inherited and your acquired hypercoagulable states. So factor V Leiden, which is your most common, prothrombin, which is less common, along with protein C and S deficiency. And then you can get antithrombin 3 deficiency as well, which again is very rare. And then your malignancy, so cancer, smoking, obesity, pregnancy are all like common acquired causes as well. Cool. Next question. So we've got a 65-year-old man who presents with a petechial rash over his leg and unusual bruising. He also has fatigue, shortness of breath, pallor, unusual bruising, other places as well, and has a recent history of receiving chemotherapy for lung cancer. You suspect possible Myelodysplastic syndrome. Which of the following findings points towards this diagnosis? There's a lot to read, so I'll give you a bit longer on this one. Just a few more seconds. Okay, so you can see a mix of answers, so E and C here. So the answer is actually A. So in MDS, you have this macrocytic anemia. It's one of the common causes of this. Where is it? So yeah, so you can get a normocytic or macrocytic anemia, but macrocytic anemia is the more common picture here. You can get a leukopenia and a thrombocytopenia as well. And on blood smears, you can get Hal-Jolly bodies, where you can see the nucleated red blood cells, and the pseudo-Plager-Hute anomaly, where the neutrophils are hyposegmented with nuclei. And this is normally seen if they've been undergoing chemotherapy. So this patient's been receiving chemotherapy, which kind of links in with this. And then on bone marrow biopsy, you can get this kind of hypercellular dysplastic bone marrow, and you'll get loads of cells from different cell lines with loads of blasts as well. and you'll get these ring sideroblasts. So you'll see the ring around the red blood cells. And the main management for this is usually watch and wait, have supportive treatments, things like transfusion, chemotherapy, and stem cell transplant. So there's different classifications of myelodysplastic syndrome, and usually it's based on the type of cell lineage. Sometimes you can have a mix of it, or just have one cell line. And then there's also this kind of unclassifiable classification where it's a mix of mature cells that look abnormal or have normal cells with DNA mutations as well. And then I put this in here just to give you a picture of what you'd find on your bone marrow biopsy. So you get these blast cells, get these large abnormal platelets as well. And here you can see these small neutrophils. And you can see this basophilic stippling as well here. And these are the kind of iron rings you'll see in the red blood cells, which are your sideroblastic red blood cells. Okay, and then myeloproliferative disorders, you have 3 different type causes, and it can come as a triad as well. So you got your primary myelofibrosis, your polycythemia vera, and essential thrombocythemia. And I put this table in here just to kind of compare them. So your MDS is your ineffective hemopoiesis, and it can have the risk of evolving into AML. And myeloproliferative, you have the risk of also progressing into AML or myelofibrosis. And the key mutation you want to remember is JAK2, but the others include MPL and CALR. And this is just a quick whistle-stop tour of kind of presentations in malignancy. So the key red flags that you want to look out for your B symptoms. So this sudden weight loss, night sweats, fevers, recurrent infections. And then other things you look for is kind of unexplained lumps and bumps, which may be painless, changes to any bodily functions such as bleeding, bruising, changes to bowel habits, for example, breathing difficulties. If you've got lung cancer, for example, painless jaundice. If you've got any sort of cancers of the biliary tree or the head of the pancreas, for example, and then any sort of new pain, headaches, or neurological symptoms. If they're age 50 or older, and if they have a family history of cancer. Then the other things you kind of want to look at is the 4 different categories. So looking for local symptoms, metastatic, systemic, and looking at any cause of indication of paraneoplastic malignancies as well. So just kind of created this table just for your revision. And then this is just differentiating the different types of cancer. So you've got your benign tumours, and then you've got your malignancies. So if something's benign, it's going to be slow growing. They're going to be well circumcised and encapsulated within the fibrous tissue, and they won't be invasive, so they don't have a metastatic potential. The cell types usually are well differentiated, and they tend to resemble their original cell type within whatever tissue they're in. And the nuclear cytoplasmic ratio tends to be normal, and they have very few mitotic cells. Whereas in malignancy, the tumour itself will be fast growing, it's poorly circumcised, not encapsulated, and it's invasive and has a much higher metastatic potential, especially because it can invade into surrounding tissue and into your bloodstream. The cells, they vary in their stage of differentiation, and they don't necessarily resemble their local tissue cells. The cells and the nuclei itself vary in shape, and many of them tend to be mitotic, and that they have a high nucleocytoplasmic ratio. And this nucleocytoplasmic ratio is one of the key things that you look for to identify if they're malignant or not. Okay, and then I've just put this slide in here just for you to know the key kind of nomenclature of different types of tumours. And then the two common types of two common types of cancers you'll see is your adenocarcinomas, which are usually granular cells, and squamous cell carcinomas, which are from your keratinocytes. And then the key principles of managing cancer is you need to get some sort of biopsy for histology in order to get that formal diagnosis. Staging and grading of the tumour is key here. So with staging, it's your TNM. So looking at the tumour itself, looking at the lymph nodes and seeing if it's spread to the lymph nodes and how many it's spread to, and then looking for the existence of any metastasis in other parts of the body as well. And then grading, it looks at the actual cell types itself. And then the key, some key grading systems that exist that you might want to know for your exams are the Gleason for prostate cancer, Vigo for gynae cancers, Ann Arbor for lymphomas, and Dukes for colorectal cancers. And all cancer patients are discussed within an MDT, and that MDT outcome will kind of dictate what the plan will be going forward. So whether it's chemotherapy, radiotherapy, surgical, combination of these, or palliative interventions, which can also include any of these three. Okay. So that is the end of that presentation. If anyone has any questions, please do post it in the chat. I can answer them, and it would be very grateful if you guys could fill in the feedback form for us too. I'll post the link in the chat as well. And thank you, Andrew, for doing this session with me as well.
Yep, that's no problem. Thank you everyone for coming.
And good luck with the exam, guys.